So once again, the same protocol will go forth. We will have three presenters, Quinn Cannon, Kate Berg, and Dane Lyman. And they will go in that order. They will introduce themselves. Following the completion of their three talks, we will have questions and answers for them. If you've thought of any other questions for the previous speakers, we can take the roving microphone to them, so we can still do that. Then following that, we will have our remote speaker still doing it. We're still good with that? Okay, so our seventh resident, whom we've isolated because he's just not attractive enough to be here. That's actually not the case. He tested positive for COVID, so we're keeping him where he's safe from us and we're safe from him. But we'll take advantage of our technology. So, Quinn, you're up.
So my name is Quinn Cannon. I am a third-year resident here at McKay. And my presentation is called Check It at Home, Adventures in Home Blood Pressure Measurements. This is my wife and child at Lagoon this year. We have season passes and we stop on our way to visit family in Salt Lake. I think like 45 minutes is the ideal Lagoon trip. With a 1-year-old, of course. I'm going to Vermilion, South Dakota when I graduate. I've signed a contract out there with Sanford Health. Kate is from North Dakota. She told me the weather's very nice and that I should enjoy it. A little bit of snow in the winter, but nothing too bad. And really excited the University of South Dakota is there. So this slide is, I put in to say that, you know, oftentimes we can see where we're going or we can see what is eventually going to happen, but it's, you know, getting to that place, getting to the other side of the river can be really hard. I remember I used to wonder about internet, you know, how are we going to carry internet in our pockets? You know, how I used to worry about keyboards. I was like, well, how are we going to be able to type? How are we going to be able to access that? And now we, of course, all know what that solution is, but you know, there were Blackberries, there were lots of things along the way that we tried out, and we've eventually ended up with just the touch keyboard. Other examples are, hey, my house is empty all the time, or I have this vacation home. Wouldn't it be awesome if someone else could take advantage of that? Or, of course, we all know the continuous glucose monitor. So, you know, we're all doctors. I think good way to get engaged is actually think of a patient sitting in front of you. So 52-year-old female, she has really difficult to control hypertension, and she comes in to follow up with you. Blood pressure is 148/102. She says she takes her medication religiously. She says every time she walks to the local pharmacy, blood pressures are normal because she doesn't have a cuff at home. Nothing on physical exam. She's had a little bit of a workup for secondary causes. She does appear mildly anxious. So, of course, what do? Well, you increase her blood pressure medication. And what's going to happen with her? So you're probably going to say something like follow up in a couple weeks, follow up in a month. If you work in a resident clinic, probably you'll graduate and then another resident will see her, and she'll just do that a few times. You know, you could continue to look for causes of secondary hypertension, spend her money, spend the system's money. Or she could develop syncope, right? If you're increasing her blood pressure medications too much, then there are problems associated with that, as we all know. So the most important part of this encounter is that she's seeing you, she's one of your patients at your clinic, and according to the medical record, she has uncontrolled hypertension. Because despite your interventions, despite the medication that she's on, you are not doing your job of controlling her medication or her blood pressure. So I had several experiences like that when I was a first-year resident. Then, of course, COVID hit in March, and it became controlling these sorts of issues even more difficult because we weren't, even at the beginning, we weren't even seeing people for non-urgent issues, you know, blood pressure, things like that, totally fell under off the radar on the table. So all of this got me started to think about a quality improvement project that maybe I could work on. As Bryce discussed, quality improvement is systematic. You know, you're trying to look for one way that you can intervene And then you're also trying to measure, hey, did that intervention get us towards our goal? Did it, was it successful? And sometimes it's just as useful to have an unsuccessful quality improvement project as a successful one, because it shows you what doesn't work. I'm one of the residents that works down at Midtown Community Health Center. That's where my primary clinic is. We have a general clinic and an urgent care down there. We largely serve Ogden's immigrant and uninsured, underinsured community. This is the same health center where our OB clinic is that Bryce was discussing. We do have a federally subsidized pharmacy, which is amazing. And we also have an online patient portal that's connected to something called the Helo app, which is an app that the patients will actually have on their phone. So at the beginning of this, we discovered about 4,300 patients with hypertension down there. 78% of those were categorized as uncontrolled based on the most recent blood pressure measurement. And again, that has to be an actual clinical encounter. If somebody calls in, or you call them and say, hey, did the medication change affect your blood pressure? That's not going to actually change whether they're classified as controlled or uncontrolled. We do distribute, when I started, we were distributing blood pressure logs and manual blood pressure cuffs to patients for them to go check their blood pressure at home. And then eye-level observation at the time was that compliance with just getting a cuff from the pharmacy and taking a piece of paper home, filling it out, and bringing it back in to actually review with a physician, that the compliance with that was very poor. So I started with a survey. 39 patients were surveyed by phone. I was sure to include patients who had been given free blood pressure cuffs from our clinic to get information from them. I asked questions about equipment, frequency of checking, if they were keeping their logs, and then also if any visits were triggered based on their measurements. And non-compliant patients were identified and followed up with 2 months later in a separate cohort. So these were the survey results. Found that 77% of the patients were non-compliant with, after being asked to check their blood pressures at home. Only 4% of them were making daily blood pressure checks. 26% were keeping some sort of a log, and that was actually defined pretty loosely. So, and then 12.8% had had an appointment triggered based on a blood pressure or a series of blood pressure measurements that they'd taken on themselves at home. So the non-compliant cohort, I identified, and then I followed up with them 2 months later, and I got more than a 50% response rate, which was pretty amazing. Had to make a lot of phone calls and even sent some text messages. 25% had made follow-up appointments or had started keeping the logs after having the first phone call, and 82% expressed intentions of improving their home blood pressure checks. So what was next? At the time, COVID had just hit, and the idea was, well, how can we get these patients who aren't able to, or they're either too scared to come into the clinic, or they don't necessarily want to, or they can't make an appointment, how can we get actual blood pressure measurements on them and get them into our medical record and identify which ones need better control? So really, we need some piece of technology, something on their end that is going to interface with our medical record. And we do have the Helo app that is already integrated with the medical record. Patients can send messages back and forth with their provider. So the idea was perhaps we could use the Helo app to interface with a blood pressure device that would Bluetooth back and forth between the phone and the blood pressure device, and then that information would then be sent over into the electronic medical record. So this became pretty interesting, and it was really an educational experience for me because I got to interface with reps from all these different companies. These were the 6 or 7 companies that Helo said that they were able to interface with and that it wouldn't be an issue to work with. And so we interviewed different reps, and we got prices, and we got different samples and things to try out and to work with. And that was a little bit like buying a used car. One of the thoughts that we didn't necessarily have at the time, but I think it's important to bring up, is that sometimes homogeneity can be a bad thing. So the boots on the left were German soldier issue boots, and when they invaded Russia, they found out that the metal studs on the bottom conducted the cold from the floor perfectly up into the toes and increased the incidence of frostbite. So every soldier had to wear the exact same shoe. Since Germans love homogeneity, sometimes there can be issues with that. So we applied and we received HRSA grant funding. We did co-purchase Bluetooth-enabled machines with the patients. We wanted to co-purchase so that patients would have a level of buy-in. We didn't want them just to be getting a free blood pressure cuff. We wanted them to actually put up just a little bit of money so that we were selecting patients who were maybe going to be a little more committed to the program. Currently, we have 56 patients active in the program. We did hire a case manager as well who reaches out to the patient and kind of works as an interface between the patient and the providers, stops us from having to follow up and do all of the details on this. Of course, we're hoping for many more than 56 patients, but it's taking some time to get people enrolled. And right now, we are getting the reports from the blood pressure cuffs. We're getting them through email reports. So it's not directly integrated into the electronic medical record yet, but the email reports are then transcribed by the case manager. And then, of course, despite maybe our hopes, the app and EMR interface has not been seamless. So these are our current results. We have a monthly attrition of 2%. Compliance with the assistance of the case manager who's working with this is 84%, and then electronic logs are at 96%, where there are just a couple patients out there who still want to write it down by hand and then discuss that with the case manager over the phone. So what are the cons of this system if we were to get it up and running? What are the things that are the new issues we're going to have to deal with? One, there are HIPAA concerns with this information. Just having it out there, having it on an app on the patient's phone, having it sent all over. Without the grant money that we got, this wouldn't be feasible. The case manager, all those other things. The blood pressure cuffs are not cheap. Certainly our patients, the vast majority of them would not pay for the full price for one of them. It is a little bit of an information overload. So we all know as physicians we make decisions based on a limited amount of data, and sometimes adding a whole bunch more data into that isn't necessarily helpful. There's potential liability. I think this is something that we haven't explored yet, but somebody has a blood pressure of 210 over 130 and they send out that through the app, and they think, well, now my doctor knows about it, so if he cares, he'll give me a call, but it's Friday and the patient doesn't get called till Tuesday. Obviously, EMR application woes. I think part of that was also going back to the German soldier boots. Maybe it's not the best idea to just choose one brand or choose one thing right at the beginning if you don't have a system that's up and running, because it may be that you choose the wrong boot right off the bat. It's good to have some diversity in the beginning, and then maybe after a year or 6 months of using different cuffs, then you can say, okay, well, we really like this one. We know that it works. We're going to stick with it. And we don't have any long-term data, of course. There are many pros with this, but some of the ones that I like is, I have a lot of OB patients who have issues with their blood sugar, and when you see their blood sugar logs, it's pretty amazing that every single morning blood sugar is between 92 and 95, and yet the spot blood sugar in clinic is 174. We are teaching our patients how to fish. They're involved in their medical care, and you're able to see them and to get them to do something at home, not just come to clinic and have the doctor take care of everything. one of the biggest is that we're easily able to identify people who fall off the wagon, right? So you have 100 patients out there with these cuffs. It's pretty easy to find out which ones stop using them and to reach out to them or to try to get them to schedule an appointment to find out maybe what went wrong, maybe the batteries ran out, maybe there's an easy fix and we can get them back enrolled in the system. You're able to focus your efforts, your phone calls on those patients specifically and hopefully avoid some wasted time. We all know this is the way of the future. We all know this is how blood pressure is going to be managed, 10, 20 years from now. We are going to be getting information from patients that based on their blood pressure throughout the day, hopefully, but we don't exactly know what that's going to look like, and it's going to take a lot of small efforts in different areas to make that work. And I'd also like to say, we tried to cross the river, jumped across, landed on a stone, and got our boots wet, but hey, we're making an effort. So best laid plans of mice and men often go awry. We did not cross the river. Obviously we were very optimistic about this and we're going to continue to work on it. 86 patients enrolled right now. Identifying the patients who need attention makes intervention more manageable. I already discussed homogeneity versus diversity. I think homogeneity too early in a process is a bad thing, and that may be an issue that we had. So obviously, it's important for patients to be involved, but when you can automate things as much as possible, as in they check their blood pressure cuff, it Bluetooths their phone, which automatically connects to the medical record, that gives them, it makes it easier for them to be involved, which was great. And then obviously small failures can maybe lead to big successes someday. I'd like to acknowledge Dr. Reifleman and Carissa Monroy, Tiffany Hahn, Shelley Reeves, and Juali Echevarria.
My name is Kate Berg, and I'm a third-year family medicine resident here at McCady Hospital in Ogden. Today I'll be talking about workplace violence, trying to understand it and discuss some things that might help reduce workplace violence in the future. Do you know? Oh, nice. Okay. I have no financial disclosures or conflicts of interest today. And my plans after residency include keeping Utah our home. My fiance and I are both from North Dakota. The weather is great there, in case you don't know, especially this summer. But I'll be joining the Intermountain Clinic at Layton, and I'm so excited to continue with the residency as part-time faculty as well. So I want to play a video for you that was recently shown on KSL News in February of this year that brings some light to my topic today.
Healthcare workers, touted as the heroes of the pandemic, have not just taken a mental beating, but a physical one. How often it happens and the intensity of the abuse may shock you.
Yeah, Dee, court documents show nurses punched, kicked, and getting their hair ripped out. KSL investigators have spent months now looking for data, talking with hospitals and healthcare workers to find out what is happening in Utah hospitals.
It is tough to watch. A sudden, unprovoked punch, followed by attacks on 2 nurses and a security guard who was punched 12 times. It happened at a Provo hospital in 2020, an attack that sent 3 people to the ER.
I was punched in the chest by a patient.
Assaults on healthcare workers are not new.
So I got slapped in the face, punched in the stomach.
But the reality is, over the past couple of years, it has gotten worse.
I've been punched, hit, none of that stuff did I sign up for.
And to those who say it's just all part of the job, they have a message.
It's not part of the job.
Take a look at these numbers from the Utah Hospital Association showing reported workforce violence in Utah's 4 major healthcare systems. In total, nearly 22,000 reports of physical or verbal abuse in 3 years, with a 13% jump since the beginning of the pandemic. The KSL investigators spoke with dozens of healthcare workers, professionals being screamed at, spit on, punched, and worse. But none were willing to go on camera for this story, all fearful of losing their jobs.
So what is workplace violence? In simple terms, it's the physical or psychological actions that are intended to cause harm to persons at work. These violent actions can include kicking, hitting, spitting, biting, pinching, and the list could go on. Violence also includes verbal or written actions that are intended to cause harm as well. It's estimated that 25% of healthcare workers have experienced some type of workplace violence. However, the number of violent incidents that involve healthcare workers is likely much higher due to underreporting. And the estimated reality of the actual cases is probably closer to 3 times higher than what is reported. There are obviously many negative consequences associated with workplace violence. It includes both the physical and psychological harm to the caregivers, but it can spread deeper to a department level or a system level. Obviously, things that can happen are effective morale and ultimately lead to caregivers leaving their jobs. And therefore, workplace violence also has financial implications if this physical and psychological implications aren't enough. People who experience frequent violence are more likely to leave their job, resulting in higher turnover costs. It's estimated that turnover of registered nurses at hospitals averages between $5 and $8 million. And one study found that at large U.S. hospitals, it could cost on average of $3,000 per one incident of workplace violence, once you factor in sick leave, disability, staffing shortages, and overtime pay. And then since the pandemic, incidents of workplace violence have increased. This graph is showing us the number of days that's spent away from work from healthcare-related workplace violent injuries compared to other industries. And as you can see in the Bureau of Labor statistics data here, violence-related injuries results in 4 times more days away from work compared to other industries. So let's talk briefly about some potential etiologies of violence in the workplace, because often there's many factors at play. While workplace violence is most commonly a patient causing harm to a caregiver, it's not always the case, and so I don't want to paint that picture. But I do want to shed light on the challenging situations that patients are oftentimes put through in the hospital. Their autonomy is significantly decreased. They're worried about what will happen to them or their family, and the financial burden is very real. In combination with those stressors, in the presence of substance abuse or medication side effects and interactions, infections if they're at play, or other psychoses, there's a scenario that's created in which increased risk of workplace violence might occur. Some of the things that can also contribute to increased risk of workplace violence is staffing shortages, the role or the duty of the caregiver if they're at increased risk of exposure, or the absence of workplace violence prevention programs. So at Intermountain Hospitals, specifically at McCady Hospital, there's already a well-developed program to report and try to prevent the events of workplace violence, and they have a process in place called a safety swarm, much like the swarm that happens when the bees form a new colony, and that swarm helps protect the queen bee. The current safety swarm process involves gathering the small group of people that are most relevantly involved with the caregiver that was injured to assess the situation, make a plan, and then hopefully prevent further incidences going forward. That incident is then reported to employee health and security if needed, and then lastly OSHA if it's indicated, depending on the injury. This slide is not meant to be readable, but I just want you to see the length of the swarm form process. So when a safety event occurs, the caregiver goes on, fill this out, and then this is documented, and this is ultimately where we collected our data from. So how can we help? In order to decrease violence in the workplace, we have to understand some key aspects of what's occurring. And my goals for this project were to identify any patterns of workplace violence that parsed out from our data, learn about reasons for underreporting of the workplace violent events, and then generate some actions that could both keep caregivers and patients safe while increasing the rate of reporting. To accomplish this, we did a retrospective analysis of the reported workplace violence events that occurred at McCady Hospital in the year of 2021. And we looked at who, where, what, and how injuries occurred based on the report that was filled out at the time of the safety swarm that I mentioned earlier. Injuries by job were most commonly occurring in caregivers who were working as certified nursing assistants or CNAs, medical assistants, or technicians. And oftentimes CNAs and patient technicians are asked to perform a role as a patient safety attendant or a PSA. And in this role, they'll sit with the patient in the room next to the bed to help redirect or divert any behaviors or things that the patient might do to hurt themselves or other caregivers. Nurses are second most commonly injured at 37%. Security personnel have reported 12% of workplace violent injuries. And lastly, there's this other category of 2% that includes physicians, other providers, physical or occupational therapists, respiratory therapists, etc. So we're quite shielded as providers from workplace violence. Injuries are most often occurring in patient rooms, and you can see that the behavioral health department and emergency departments were the next most common locations. And again, illustrated here, the caregivers in the behavioral health are some of the most at-risk caregivers. However, this data shows that workplace violence is happening all throughout the entire hospital, including the medical surgical floors, as they have the highest, second highest reported location of workplace violence, with the emergency department and the ICU following. Most often, the injury is caused by an adult patient. I do want to point out that there have been some patient family members who have caused the injury to caregivers. In over 90% of activity, or in cases, the caregiver reported that their activity that they were doing at the time of the injury was caring for a difficult patient when the injury occurred. And the most common precursor that led up to an injured caregiver was that the patient was suspected to have an underlying mental impairment. The second most common precursor occurred while a patient had a patient safety attendant, or the PSA that I mentioned earlier, present in the room. Just them being in the room that much longer increases their risk of exposure for potential violence. And some other precursors that included that were also at play were chemically impaired patients, patients in restraints, and then if the patients placed on a blue sheet that prevented them from leaving the hospital. Oh, sorry, click. Okay, so in speaking with some of the caregivers, some thoughts surfaced as to what intervention could help. It could result in getting help sooner. As caregivers pointed out, that recognizing the escalating event and getting help sooner could prevent these violent events. Some reasons that were listed for not reporting workplace violence included the paperwork, the time that it takes to complete the safety SORM that I mentioned before, and this is especially in the setting of being short-staffed. Another response was that they felt like physical events were actually part of the job, and that was an okay thing that it was happening. And then some other people said that they didn't want to risk the consequences for them or the patient by reporting the incident. And lastly, caregivers felt that they didn't call for help soon enough due to staffing shortages, or that the situation escalated so quickly that they weren't able to call for help. So there are some interventions that are currently in place. Green is the color of safety with our hospital, and so you kind of see a theme here. But there's a current strategy that we have is placing this green piece of paper, and literally all it says on it is, please talk to the nurse before entering. And this allows people to be briefed on a patient before entering the room, so people can be on the same page. There's something called a code green, where they call overhead. No, just kidding. It's not called overhead. There's a button that you click that notifies 2 security officers and the nursing house supervisor to present immediately to bedside to help with de-escalation. And now the EHR has a disruptive behavior warning. If a patient's had a previous event, it gives the details of what happened with that event, so the provider can anticipate possible or plan for possible scenarios. Future work for interventions includes simplifying the reporting process, especially the paperwork, because no one likes paperwork. And a large portion of the current workplace violence training is done now on computer modules. We do simulations for Code Blue, and so I wonder if there's a potential option for the caregivers that are at highest risk of workplace violence to participate in a simulated de-escalation event to improve their skills. And then lastly, there's much work that's being done at the legislation level, and just in March of this year, our governor signed a bill that increases the penalties of battery or assault against healthcare workers. So the key findings that I wanted to reiterate here is caregiver injuries are underreported, and caregivers sitting in patient rooms have the highest exposure, and we should ensure that they're adequately trained to handle the situations effectively to prevent injuries to themselves or patients. There are several high-risk areas of the hospital that we would anticipate, like behavioral health units and the emergency department, but it is important to know that violence is occurring all throughout the hospital. And most importantly, workplace violence is not part of a caregiver's job. As physicians and providers, we're in a wonderful position to set the stage for respect for our coworkers. And as leaders of our team, we should understand the depth of the consequences of workplace violence. And by working together, I think we can continue to create an atmosphere that allows us to keep doing incredible things by caring for others. And that's all I have. Thank you.
My name is Dane Lyman. I'm also a third-year resident at McCady Hospital going into family medicine. My talk today is titled How Monitoring Risk Affects Patient Outcomes. And it's showing on this screen, but not up there. There we go. So, there we go. Monitoring risk, patient outcomes. To start, I have no financial disclosures nor conflicts of interests. And my next steps, I'm going to be returning to my hometown with my wife and 5 children. We're going to Blanding, Utah, where I'll work for Utah Navajo Health Services, doing full scope family medicine. So I wanted to start my talk with a quote. It says, "The art of medicine consists in amusing the patient while nature cures the disease." I heard this early on in my training, and I've thought about it frequently as I've worked through medical school and residency, mainly asking myself if what I'm doing is making any sort of a difference whatsoever. I often remind myself that Voltaire said this in the middle of the 18th century when the leading causes of death were tuberculosis and typhoid and childbirth and even bloodletting, which was done by physicians. So a lot has changed in healthcare. We probably are making more of a difference than physicians were making then, and its evolution continues. I wanted to talk today about what I think is kind of the next big deal in primary care, sort of a policy issue, and that is value-based care and the Accountable Care Organization, or the ACO. So what is an ACO? Briefly, it's a group of physicians and hospitals who team with a health insurance company to provide care for a patient with the goal of reducing costs. They do this by visiting the PCP more frequently so that their chronic conditions can be better managed. We're also trying to avoid unnecessary trips to the ER, prevent admissions that don't need to happen, and address their social determinants of health. The way that people get paid in ACOs is quite different from what we've known traditionally. Moving away from fee-for-service, we're now going to a budgeted healthcare model. So the health insurance company will provide a lump sum of cash for a patient for a 12-month period. And whatever that patient needs as far as their health care is concerned, whether that be primary care services, urgent care services, or emergent care, hospital care, surgery, imaging, you name it, it is supposed to come from that budget. And of course, the goal is to be a good steward of that money and to try and stay within the budget. Any surplus that is left over at the end of the year, if you're able to manage that, will go back to the key players. The health insurance will take a cut, and the people who are involved in the patient's care will also get some incentive for the good care that they provided for that patient, hopefully a bonus for the physician. This begs the question as to how this payment is determined, and risk is the driving factor. A patient's risk is determined by their problem list, and there are certain problems on a problem list that are, I guess, weightier to health insurance companies. We've labeled these as hierarchical care conditions or codes, HCCs for short, and these are typically chronic conditions that have simply been associated with a higher probability of poor health outcomes and higher cost to the system. Ideally, these are all kind of addressed, captured, and placed on the problem list at a patient's yearly physical or annual wellness visit. And we'll see some examples of that a little later. But you can tell that the emphasis on accurately coding and capturing these HCCs is paramount in this new system. Why am I talking about this? I presented a poster here last year where we looked at our HCC capture rate at Porter Clinic, where the residents work, and we were not doing very well compared to our community partners. So we implemented some interventions through a QI project, mainly education and emphasis. And as you can see, 2019 is in the gray, 2020 is in the red. We were coding more accurately, capturing more HCCs. I had another graph which showed that our income for the clinic improved significantly as well. So better coding, more income, 2 thumbs up, but I still had the question as to whether or not this was actually making a difference for the health of our patients. I want to show you a little bit about how this might work. So you may have a patient that comes in for an annual wellness visit and you pull up their chart and you see this problem list. It's meant to be intimidating. This is a fake patient from our EMR, but you can see here the HCCs. They have a little HCC in parentheses next to the problem. Red means that they have not been captured or addressed. You can see on there things like CKD, diabetes, dialysis, rheumatoid arthritis, AFib, depression. The list goes on. There are over 3,500 HCCs that you could possibly code, so we're not going to come close to naming all of them. But this physician who is taking care of this patient has captured 4 HCCs for this visit, and they've turned from red to black. And that feels really good to click that button. It decreases our anxiety seeing less red on the screen, and that's kind of the goal. This problem list will be submitted with the bill to the insurance company, and the insurance company will look at all these HCCs. Each HCC is associated with a risk score, and the sum total of those risk scores determines the patient's overall risk, and that in turn determines how much money they'll get for the next 12 months. But again, my question is whether or not clicking this button and decreasing the red text on a screen is actually leading to better outcomes for our patients, or are we just playing this game with the health insurance companies where we're trying to secure more funding for our patients, which is arguably very important. As I was kind of mulling over this question, I actually found another quote that kind of encapsulated some of the frustrations that I was feeling as I was wondering about this issue, and I wanted to share that one with you as well. It says, "The art of medicine consists in distracting the physician with menial tasks while nature cures the disease and someone else makes the money." We don't know exactly who said it. Good authority says it was a third-year resident at McCady Hospital. Satire and sarcasm aside, of course, as we move to this new value-based care system, there is good data to drive this change. One of the leading pieces of literature that we've referred to throughout this process is titled The White Paper, written by Humedica out of Boston. And they were able to analyze the data from 4 million patients who are under the care of 26 medical groups across all 50 United States. And among the many questions that they asked as they looked at this data was whether or not accurate coding and risk monitoring did affect patient outcomes. So I wanted to share some of their data before I got into my own. This chart comes from the white paper. There's a lot going on here that's interesting that we could talk about, but I want to draw your attention to this gray box that says that 37% of patients with a major chronic condition are uncoded, and that was higher than I guess I was expecting. Why does that matter? Well, they broke these patients down into coded versus uncoded, and they were able to stratify their risk. As you can see on the left, we have patients who are coded, and they've divided them into very high risk, and moderate risk. On the right are those who are uncoded, and you'll notice that there's a much higher proportion of those patients who fall into the very high risk category. You may be wondering how they were able to determine this risk. Well, they were looking at objective measures of chronic conditions like an A1C for diabetes, blood pressure for hypertension, LDL for dyslipidemia, and from how well controlled or uncontrolled those things were, they're able to extrapolate a risk score. This forest plot here looks again at whether these patients were mostly coded or uncoded and what kind of care utilization they were engaging in. So on the top, kind of to the right, you'll see those patients who were mostly uncoded, and they were accessing acute care far more frequently than those who were more coded. They were visiting the ER, they were getting admitted, and when admitted, were admitted for longer periods of time, thus incurring more cost to the system. Compared to those who were more coded, and they, by and large, were seen in the outpatient setting by their PCPs. So the white paper purports some interesting findings. I wanted to know if that could be observed in our region with our patients here in northern Utah. I was able to gain access to a pool of patients numbering 1,380, which is far fewer than 4 million, but they came from our region, and they weren't just confined to the Porter Clinic. They spanned from Salt Lake all the way up to Logan and even into Idaho. All of these patients had Medicare, and we were looking at data pertaining to the calendar year of 2021 for these people. And we were looking at some of the same measures that the white paper was observing: ER visits, how well coded they were, and whether or not they had had their annual wellness visit. Some baselines from what we found. First, we looked just basic whether or not they had had an annual wellness visit. And 78% of them had had an annual wellness visit, so not bad in that regard. Then we looked at whether these patients were mostly coded or mostly uncoded. The yellow there is mostly coded, 62%, again, not bad, right in line with the national average. Next, as we extrapolated the data, we wanted to see how annual wellness visits had a bearing on ER visits. So we looked at the visit rate on average between these two pools. The way to understand this graph is if you look at the left column, imagine yourself as a patient that did not have an annual wellness visit in 2021. You went to the ER 0.62 times on average. Compared to the column on the right, those are patients who did have an annual wellness visit. They visited the ER only 0.3 times in 2021. Pretty dramatic difference. This looks at similar qualifications, kind of the same pool of patients, but in a little different light. Here, instead of looking at ER visit rates, we're looking at the proportion of patients in the total pool that visited the ER. So on the left, annual wellness visit did occur. Only 28%, as highlighted in orange there, visited the ER. The yellow beneath is simply those patients that did not, so the remaining 62%. And then on the right, we have those who did not have an annual wellness visit, and 46% of them did visit the ER. Then our third and final graph shows the difference between coded patients and uncoded patients, again looking at the total population and the percentages of each that visited the ER. On the left, those who were coded, you can see 37% accessed the ER compared to the 31% of those who were uncoded on the right. It's kind of interesting. So key takeaways. I think the most dramatic thing that we realized with this analysis was that at least for this patient pool, for this period of time, annual wellness visits did seem to correlate with fewer ER visits. And of course, this is right in line with value-based care and the Accountable Care Organization. Decreased cost to the system. ER visits could possibly be an indication of a surrogate marker for patient health, and it could lead to increased income for the physician, so positive in all regards. The surprising finding, I think, was that final graph where coded risk, the more coded you were, did not necessarily correlate with fewer visits to the ER, or a decreased proportion of those patients visiting the ER. And I think that there are two caveats that need to be mentioned with this. First, the time frame that we are looking at is 2021, which is in the midst of the COVID-19 pandemic. There was this virus circulating in the community that caused some pretty severe respiratory symptoms in some patients, requiring a visit to the ER and potentially admission. So that alone could have been boosting the numbers in all regards. Also, with the COVID-19 pandemic, I know at least in our health system, if a patient wanted to see their PCP, but they were exhibiting signs or symptoms of COVID-19, they were encouraged to either schedule a video visit, some sort of virtual visit, or if they felt like they needed to be evaluated in person, they were asked to go to the Instacare or the ER. So as a matter of policy, we were also funneling some patients more to this venue. Not that that was the wrong thing to do given the circumstance, but it was something that's a little out of the ordinary, not necessarily in line with value-based care initiatives. And then lastly, I think we should pay lip service to the fact that being more coded does not make you more healthy. As we saw, there are still very high-risk patients who have accurate problem lists, and they very well may need a justified visit to the ER. So conclusions, kind of referring back to this quote by the anonymous third-year resident, are physicians simply distracting themselves with menial tasks, focusing on turning red text black while our patients bear no benefit? My answer from analyzing this is probably not. I think that there is some method to this madness and that we really are doing some good. And of course, a balanced approach of kind of going through the necessary steps to secure funding for our patients as dictated by the health insurance, coupled with competent, evidence-based, compassionate care is the best way forward. If there's one thing that maybe I'd want you to remember from this analysis would be this case for annual wellness visits. It does seem that performing these is making a difference for our patients, for the system. And so if you are able to encourage a patient to get one, do it. If your clinic provides these, make it a focus. Moving forward and next steps, I think that we just need to continue to monitor these metrics, increase our sample size, see what happens when COVID is not an issue, and I imagine that we'll start to see this data flesh out and look more like the white paper. I, of course, would like to thank my team. Gathering and analyzing this data would not have been easy or palatable without them, and I'd like to thank all of you for your time and your attention. Thanks.
So just a quick comment on Kate's So before COVID struck in 2019, I attended a very small conference on ultrasound technique in Florida. There was about 15 participants in this all-day conference. It was really excellent. All the other conference attendees were emergency room doctors, and they were from various places in the country, none from right here. And in the course of getting to know them during this day of very intimate training, it turned out that every single one of them carried a firearm in the emergency room. So there's a lot of concern about violence. So questions for these three fine presenters?
I have a question for Kate. So a lot of mental health providers have to go through CPI, painting with broad strokes, have to go through CPI training or something similar to be able to continue working on a behavioral health unit. And I'm curious if people that are being used as PSAs throughout the hospital have to go through similar training, and what your thoughts would be on sort of mandating that for folks that are not working in an acutely behavioral health setting, but on, you know, a regular ward.
Yeah, I think the goals are to drift towards that, especially for the PSAs that are not getting that training now. They're working on it.
Yeah, just an observation relative to the impact of the annual wellness visit, which as a very recently retired primary care provider, we tried to do those, and I think they're very valuable. I would argue that the correlation with increased ER visits, utilization, and less annual wellness visits is not a reflection of the benefit of the wellness visit, but the attitude of the patient. And people that are not coming in for wellness visits are going to the ER because they are just those type of people. And I would also argue that I think we are just working for companies and insurance companies, and that the frustration level amongst primary care providers in dealing with increasingly complex EMRs created by billing people with very little direct impact on positive patient outcome is a big frustration in healthcare.
I agree. And you have more experience than I do. So.
Kate, I had a question for you. So with the workplace violence incidents that occurred at McCady, like how much of them were physical versus how much were verbal? And then did it matter based on the caregiver, whether they were male or female and things like that? Like were there more verbal incidents towards female or things like that? I would just like to know a little bit more of the breakdown of that data.
Good question. Gender was not parsed out, at least in the data set that I had. That would be interesting to know. And then the first part of the question about verbal, the reports that we looked at were all physical, so they were underreported.
Brian, we are all a violent society. Everybody should be involved, and I don't know the answer to it. But we got to get rid of this violence in the United States of America.
I agree.
Yes, that would be wonderful if we could solve that problem. So, Clark, what's our plan as far as our next speaker? Oh, another question. Excellent.
I was just going to ask Dr. Cannon if he had any thoughts on a solution to the problem between the interface with technology and our medical records. And, you know, he mentioned how you might get a very high blood pressure on this automated reporting and not get it till Monday morning. Any thoughts on how to resolve that problem?
Yeah, so I didn't have time to go into it, but we do give little instructional sheets to the patients as well that tells them what to do with different levels. And then obviously it says with this range, you know, it's emergent. You either need to come to an Instacare or come to an emergency room. So that's one step, just to make sure that the patient has a way of categorizing and triaging themselves so they don't feel like they're completely dependent on the clinic to reach back out and tell them what to do. But it's definitely a work in progress, and it's difficult to really bridge that gap. So.
Okay, so just a quick comment before we turn to our seventh speaker. Dr. Bruce, I'm very disappointed in you. The electronic medical record was clearly designed with physicians in mind. It's clearly you need some sort of counseling. All of you, so a quick question. All of you who truly love your electronic medical record, raise your hand. There actually are a few. You know, so those of us who are losing hair and have more wrinkles, I mean, you remember paper charts? We could never find anything. You either had to memorize what everybody's labs and x-rays and reports were, or you just made it up because you couldn't find them. So electronic medical records, while they are clearly not designed with the physician or patient in mind, at least are better than that.
Good morning. I'm Isaac Sayers, also a third-year resident. And today we're going to be looking and surveying patterns in perioperative hemorrhage throughout the Intermountain Hospital system and at McCady Hospital specifically. Next slide, please. All right, I have no financial or other disclosures, and after I graduate, I've signed for an OB fellowship in Memphis, Tennessee with the Clinica Medicos. A couple other disclosures, not just my funny looks, as you heard, that's keeping me out of here. I got diagnosed with COVID, so I'm going to blame any rambling on brain fog from long COVID. Also, in the interest of full disclosure and honesty, I'm wearing sweatpants under this suit. I would have gotten away with it, but we will go with full honesty here. Next slide, please. All right, so this is a big topic, looking into perioperative hemorrhage. And the assignment was given to me rather than me picking it out. And it was essentially a big spreadsheet full of PSI-9 events across the Intermountain system. So rather than start with an interesting anecdote, we're going to start with some boring bureaucratic definitions and try to get us a shared vocabulary and framework for what I was trying to do and how I approached this problem. Because the mandate I got was, take a look at these cases and see if you can come up with a solution for us. And I did about as well as you'd expect with that. But let's start with the definition, because I didn't know what a PSI was. So patient safety indicator, the Centers for Medicaid, Medicare services came up with about 90 indicators. And these were all potentially avoidable complications or iatrogenic events. And importantly, represent opportunities for improvement in the delivery of care. And we've seen examples of this among the 90 are things like in-hospital falls and catheter-associated UTIs. And the idea of these is that hospitals can look at them, look at their incidents, and try to kind of find patterns in what's going wrong and take measures, systemic measures to fix them. And we've seen that. We've all admitted patients with fall precaution orders that are hardwired into the order set. And now at McCady for about a year, there's not a patient that has a catheter that I don't know about, because it pops up on your screen, right, when you try to leave their chart. So the hope would be to look at these other PSIs and come up with similar interventions that will hopefully decrease their incidence. Next slide, please. All right, so the one we're focusing on, I got 9, 11, and 13 to choose from, and had to winnow it down just because this was a chart review and I didn't have time to look at more of them. PSI-9 is the perioperative hemorrhage or hematoma, and strictly defined, a hematoma or hemorrhage that involves a procedure to treat that following a surgery in non-pediatric patients. There's a couple exclusion criteria, those with prior coagulation disorders and cases where this was present on presentation also excludes obstetric cases. So this is the PSI 9, the PSI that we're going to focus on. Next slide, please. All right, so these PSI 9s were created, as we discussed, to give an indicator of quality that can be used to flag potential problems or successes, look for trends, identify disparities across regions, communities, and providers. So the goal, as again, was assigned, was to look at these PSI 9s and see if there's anything like that. So it's look for demographic, pathologic, or surgical trends and why these things were occurring. This was considerably more difficult than I think like catheter-associated UTIs. There's about 3 variables there, how you put it in, when you take it out, is there any cleaning? Whereas even in one type of surgery, there's multiple ways to cause a bleed. And we're doing every type of surgery except for obstetric ones. So my goal is to review the Intermountain PSI 9 events and look for any trends that would provide us an angle to work on, something that we could improve. Next slide, please. All right, so the method was reading the charts, right? So these were pretty complicated cases, involved looking across a lot of specialties and their notes to figure out what was going on in each of these cases. And I was looking for basically them to fall into 3 broad categories, and one being, well, was it a PSI 9 at all? Did it meet those criteria, or did it get flagged in our system as something else that it shouldn't have been? Also to look for systemic errors, and then to look for individual errors, and in the hopes that we could find something to work on. There were 138 events total. Excuse me, 138 events total. So I had to limit it a bit. So I did a system-wide survey of the Intermountain cases by choosing randomly 10% out of the whole system. And I tried to make that proportional by hospital. And then I looked at all the records at McKay-Dee. And basically just reviewed these notes, looked for the disparities, collected some patient demographics, collected the surgical specialties, the kind of operation it was, tried to look at anticoagulation as well, as that seemed like some low-hanging fruit in terms of something that could be looked at for post-operative bleeds. And yeah, had to extract all that data. Next slide, please. All right, we'll take a step back to the national data. You can go next slide. There's not a lot of this tabulated. This is all from the CMS website. They produced a few PDFs. And here we can see PSI 9, among others, just for a sense of perspective. And we can see that it's highlighted in red down there. 2.39 cases out of 1,000 discharges for surgery. So it's happening a lot more than, say, central venous catheter-related bloodstream infections at PSI 7, and happening a lot less per 1,000, as you see among those PSI 4 subsets, death rate among surgical inpatients with serious treatable complications. Next slide, please. All right, and here's PSI 9 specifically. This is the only nationally tabulated data we get on this, and they collected some basic demographics on that. We see the overall rate, again, 2.39, about evenly split between male and female, and they collected age and insurance data here. And we can see that not a marked difference between the observed rate between insurance or age there. But I did kind of use this as a framework in the demographic data, just a point of reference in the demographic data collected from the Intermountain system. Next slide, please. All right, so let's look at what we found in Intermountain. Next slide, please. Okay, for those of you not familiar, Intermountain spread all across Utah and Idaho, the Intermountain West. The 4 hospitals we looked at were McKay-Dee here in Ogden, Intermountain Medical Center down in Murray, the Utah Valley Hospital down in Provo, and then St. George Regional Medical Center in St. George. Next slide, please. All right, so just an overview of the data, and you can see the abbreviations I'll use throughout the rest of the slideshow. Here, UVH for Utah Valley, MKD for McKD, and IMED for Intermountain. Total events in the past 3 years, we have data from 2019 to 2021. There were 138 events, and they're distributed thusly with Utah Valley with 37, IMED with 58, St. George with 17, and McKD with 26. Next slide, please. Right, so this is from my randomly selected data where I looked at 10% just across Intermountain. I had to put that age in a normal distribution just because it lined up so nicely. We see centered right about 70 on the elderly end of things. And 83% male, I think that's artifact mostly of the small sample size, and 91% white, which tracks with our Utah demographics. Next slide, please. Okay, this is just a percentage representation pie chart of the share per hospital. And we already talked about the numbers, but here's the percents. McKD, St. George, and Utah Valley all more or less the same size. McKD is 310 beds, Utah Valley is 395, and St. George is 284. A little bit of disparity there between the rates, but also somewhat proportionate to the size of these hospitals. Next slide, please. All right, and then I also tried to figure out which surgical specialties were resulting in these PSI 9s. And so this is again from the system-wide survey. And we can see a slightly heavier representation from those you'd think that would be more at risk for bleeding, those that are dealing with blood vessels and the pump itself. So CT and vascular, highly represented across the system, as would be expected. Neuro also, I think, probably an artifact of the small sample size, and then a smattering of the other surgeries across the system. Next slide, please. All right, and then not a preventative thing, but just in terms of counting the cost, it seemed like the length of stay that patients had was a good way to quantify, well, how much financial and human suffering cost these PSI 9s are causing. So I did collect that data from the Across Intermountain survey, and we can see here stacked pretty heavily under 10 days, but there were some outliers, and some stays did last longer than 20 days. Next slide, please. All right, let's look at McKD. So over the last 3 years, we had 26 events, and 7 in 2019, 9 in 2020, and 2021. Interestingly, I don't have denominators on these yet. We're working on extracting that data in terms of total surgeries, but certainly going to be less surgeries in 2020 and 2021 due to the pandemic. So it's interesting that we're having more of these events. Next slide, please. Okay, and here's just a survey of our patient demographics, again with that heavily male skew, and this is a much bigger N that we have here, but still 70% male, 96% white, again, tracking with Utah. Did not review insurance, would have been a good thing to do when I was in all those charts. And we can see the age distribution widens out a little bit and essentially matches the national data. That histogram fell broadest in the like 40 to 64. And you can see the bulk of ours are centered around 60 years old. A little weighted toward the elderly, but certainly with some younger patients. Next slide, please. All right, I did try to review anticoagulation. That seemed like the best thing to keep track of with all these cases, and it was tricky. A lot of the notes, right, are free text without the medicine list populated in. Documentation would explicitly state it was held in special cases, and in cases where the patient was super therapeutic or overdosing on their Plavix. There was a few situations where it was commented on. They did hold it for several days. But the only consistent documentation I could find was the INR is actually in the anesthesia documentation, which is a dark place to go. Those of you, sorry to any anesthesiologists out there. That was consistently documented, but they didn't always get it. So I was unable to detect any patterns in anticoagulation. It looked like it was appropriately held. Certainly everyone operated on had a reasonable INR by the time they went to the OR. Next slide, please. Okay, so then we broke down the McKD surgical specialty shares. And in tracking with the rest of the system, CT was pretty high, general also pretty high, somewhat out of proportion to the rest of the system. And then we can see a few others that were not quite so represented. The ultimate intention of this project was to do Utah Valley Hospital as well. I haven't gotten through those, gotten through about 13 of the charts there. So 1/3 of their data. And I think that'll provide something useful for similarly sized hospitals, like which specialty is resulting in more of these bleeds. But that one's not done yet. Next slide, please. And then surgeon share. Again, keep in mind this is undenominated data. We do have one. The astute among you will notice the very obvious outlier among these surgeons, but without denominators, I don't think that this data lends itself to any obvious conclusions. It's likely noise. But that data is pending. We're trying to figure out how many surgeries each of these surgeons did. All right, next slide, please. All right, and then our outcome. I did note, so out of the 26 events, 2 of them were not PSI-9s. The most odd one was a person who had their cabbage canceled and then later had to have a nosebleed cauterized. So you can almost see how the PSI-9 got flagged, but I don't think it meets our generalizations. So that data was thrown out. There were 3 deaths out of these 26 events. These were all unrelated or only tangentially related to the hemorrhage. And then we can see the length of stay in tracking with the system-wide data was stacked toward under 10 days with a few outliers going over the 20s. Next slide, please. So conclusions and recommendations. It was the whole goal of this, right, was to provide a survey of this and see if there's any threads to chase. And that's what I did without coming to any super obvious conclusions. None of the events, none of these charts had anything that seemed obviously preventable. There's no smoking guns or obvious errors. Like I said, a few events just didn't even meet criteria for PSI-9. In fact, one down in Utah Valley was coming from an outside hospital. In the McKay-Dee system, there was a somewhat disproportionate involvement of CT surgery. In Utah Valley, it's looking to be neurosurgery that's the outlier. There's not really any nationally tabulated data on at least in the framework of PSI-9s on this, but I would assume that CT surgery is just a higher risk for this outcome. And we did good. Like all these bleeds were caught within hours or within a day, at the most. One did require 2 sendbacks to the OR, but all the others were done and the patient discharged without any further bleeding. The documentation of anticoagulation is difficult. We've already talked about EMRs, but I don't know if adding requirements, fields, pop-ups to our already overcrowded system is the best idea there. There weren't any, demographically, didn't come up with too much in the way of trends. I assume that higher skew toward males we're operating on more males. I'm not sure why we're operating on so many more males than the national average, but Utah is a funny state demographically. Next slide, please. So there's a few places to take this if any resident wants to do as much chart review as well as I've sold this to everyone. But we need to get some denominators in this data, and that stuff's all pending. Insurance status, I think, would serve as a fair proxy for socioeconomic status in these. Look up the CT neurosurgery proportions if other hospital systems have tabulated this. Look at how other hospitals are documenting anticoagulation and it's being held. And just see what the overall approach to these PSI-9s, reporting intervention and prophylaxis protocol guidelines are in other hospital systems. Next slide, please. So thanks for your patience listening to me. Thanks for listening to me virtually. Thanks to Dane, who I think admitted the patient that gave me COVID.